Hi everyone, I'm Melissa, the Clinical Nurse Consultant for Continence in the Sydney Local Health District. Today I'm going to talk about recurrent urinary tract infections in adults. I'd like to thank Rachel Gilchrist, who has helped me with this presentation. We'll start off with talking about the definitions of urinary tract infections, epidemiology and the natural history of UTIs, pathogenesis, presentation and differential diagnosis, then the assessment and then the management of UTIs. Urinary tract infection is an inflammatory reaction of the urinary tract epithelium in response to pathogenic microorganisms, most commonly bacteria. We diagnose a UTI when we can demonstrate growth of more than 10 to the 5 colony forming units per milliliter. If there are less than 10 to the 5 colony forming units per milliliter and pyuria is present, or the patient is symptomatic, the result may still be considered positive. UTIs are one of the top 20 most common reasons for presentation to primary care. Around 50 to 70% of women and 1 in 20 men will develop a UTI in their lifetime. Now we'll talk about some definitions. And it's really important that we clearly define the difference between these types of UTIs. Persistence is when the same organism is noted after 48 hours of treatment. Relapse is when the same microorganism reoccurs after 1 to 2 weeks of treatment. In other words, the organism is not eradicated from the urinary tract, even though the urine has been checked for sensitivity and the appropriate antibiotics have been given. And reinfection is when the person gets a new infection after the urine is completely sterilised. Unresolved persistent infections require further testing, imaging and onward referral. Now we'll talk about uncomplicated UTIs. These occur when a UTI happens in a patient with a structurally and functionally normal urinary tract. The majority of these patients are women with acute bacterial cystitis. They present with things like dysuria, frequency, urgency, and occasionally suprapubic pain. The causative pathogens in well patients are usually susceptible to standard antimicrobials and easily treated with a short course of targeted oral antibiotics. These patients are at a low risk of developing complications. Complicated UTIs, on the other hand, are associated with factors that increase the chance of acquiring bacteria and decrease the efficacy of therapy. As you can see in box 1, there are things like being male, being over 65, having a history of childhood UTIs, history of recent antimicrobial use, history of recent urinary tract instrumentation, nosocomial infection, symptoms are present for more than 7 days. Some factors we may be able to treat are things like diabetes, immunosuppression, indwelling catheters, we can get rid of them if at all possible. If the urinary tract is not functionally solid, that can be addressed. And sometimes things like previous prosthetic surgery, such as anything artificial like slings or artificial urinary sphincters. In general, with complicated UTIs, the urinary tract is not functionally normal. Often the patient may have a concurrent neurological condition or experience altered bladder emptying or storage function. The person may be immunocompromised. Many patients with complicated UTIs are men, and the causative bacteria may have increased virulence or antimicrobial resistance. As you can see in figure 1, there is a calculi in the renal tract, and in figure 2 this shows BPH, so benign prostatic hyperplasia. The patient may also have areas in their bladder that will trap residual urine, such as bladder diverticulum. A complicated infection is frequently caused by bacteria which have acquired antimicrobial resistance from exposure to multiple antibiotic use in the past. Recurrent complicated infections, when combined with obstruction, stones, and diabetes, can lead to urosepsis and progressive renal damage, and have potentially significant morbidity and mortality implications. Now we'll look at epidemiology and natural history. Young women have a 30 times higher chance of infections than men. However, as we age, the number of men with bacteria in their urine progressively increases. At least 20% of women and 10% of men older than 65 have bacteriuria. Once a patient has an infection, he or she is likely to develop subsequent infections. The probability of recurrent UTIs increases with the number of infections and decreases in inverse proportion to the length of time between the first and second infection. Pregnant women have the same prevalence of recurrent UTIs as their non-pregnant counterparts. However, the consequences of their bacteriuria is substantial due to the potential effects on the fetus. Pathogenesis. UTIs arise from an interplay between bacterial virulence factors, inoculum size, and host defense mechanisms. Most bacteria enter the urinary tract from the bowel, ascending through the urethra. Adherence of pathogens to the introital and/or urothelial mucosa play a significant role in this. Bacterial adherence to vaginal and/or urothelial epithelial cells is an essential step in the initiation of UTIs. This interaction is influenced by the ability of the organism to adhere, the receptive characteristics of the urothelial surface, and the fluid bathing the surface. Uropathogens have been found to attract in larger numbers to urothelium from postmenopausal women with lowered estrogen levels, leading to more recurrent UTIs in this group. E. coli is by far the most common cause of UTIs in patients without catheters or urological abnormalities or calculi. Other gram-negative organisms are also commonly found. In comparison, Citrobacter, Cerata, Pseudomonas, and Providentia are more commonly seen in the hospital setting or in aged care facilities. The normal vaginal introitus, periurethral area, and female urethra are usually colonized with lactobacilli. This normal flora forms a barrier against colonization by uropathogens. However, a change in the vaginal environment related to estrogen and pH levels may alter the flora. Antimicrobial and spermicide use may also alter the normal bacterial environment and increase the receptivity of the epithelial to uropathogens. Urine has a high osmolarity, and the concentration of urea and organic acids help inhibit bacterial growth. Although it is presumably common for bacteria to make their way into the bladder in females, whether the bacteria persists, multiplies, or infects the host depends in part on the ability of the bladder to empty. This is an important factor to recognise, as it has assessment and management implications. Okay, now we'll look at how people present with a UTI. They'll often have dysuria, frequency, urgency, and occasionally suprapubic pain. These symptoms are generally indicative of a lower urinary tract infection, but they can be seen in other conditions like OAB, STIs, bladder carcinoma, calculi, vaginitis, or bladder pain syndrome. The presence of flank pain, chills, and fever is indicative of pyelonephritis. In addition, renal or perirenal abscesses may cause fever and a flank mass and tenderness. It's important to note that malodor and cloudiness of the urine are not indicative symptoms of UTIs. In the elderly, we should not treat asymptomatic bacteria in the urine, but urinary tract abnormalities can cause and complicate bacteriuria in the older adult, so recurrent UTIs in this population warrant further evaluation. By checking serum creatinine, imaging, and onward referral for further investigations such as cystoscopy, we may identify abnormalities such as renal dysfunction, calculi, hydronephrosis, urinary retention, and bladder dysfunction. The timing and sequence of these tests will be dictated by each individual presentation. In the elderly, we need to be very suspicious of UTIs because they are a common cause of septicemia in the elderly, and sepsis may be associated with a mortality rate approaching 50%. Patients in residential aged care facilities are more commonly exposed to multi-resistant uropathogens and may have issues such as decreased mobility, incomplete bladder emptying, and fecal incontinence, which further increase the risk of UTIs and complexity of management. Now to the dreaded CAUTIs. Every patient who has a catheter inserted will have bacteria in their urine, with microscopy and culture often being positive for 2 or more organisms and showing concurrent pyuria due to the presence of the catheter. But we must not jump to treatment straight away. Treatment is not indicated for cloudy or malodorous urine in asymptomatic patients, even for those in residential aged care facilities. The absence of specific clinical signs and symptoms in the elderly makes the diagnosis of recurrent UTIs more challenging. Their symptoms are often vague, for example, abdominal discomfort or anorexia, and generalised, such as confusion. The choice of empirical antimicrobial therapy is guided by whether the infection is complicated or uncomplicated, its spectrum of activity against probable pathogens, and its potential side effects, including hepatic or renal toxicity, as dose adjustments may be required. In renal failure, the kidneys may not be able to concentrate antimicrobials, resulting in difficulty in eradicating the causative agent. The duration of antibiotic treatment varies according to the clinical situation. There are multiple medications, as you can see, and antibiotics that can be used, and these ones on the screen are reasonable choices in primary care, with uncomplicated bacterial cystitis in women warranting treatment for 5 days, whereas in men with bacterial cystitis, they should be treated for 7 days. The lower criteria for initiation of antibiotic treatment in clients in the residential aged care facilities suggests treatment of catheter-associated UTI if one or more of the following is present: either fever, new costovertebral angle tenderness, new onset delirium, or rigors. It is important to avoid treating cloudy or malodorous urine in the catheterized patient unless it is associated with symptoms. As part of the treatment of CAUTI, we need to look at the underlying reason for catheterization and remove the catheter as soon as possible and aim to avoid recatheterization. Antibiotic resistance, as we all know, is a big issue. 40 to 52% of Escherichia coli resistance is to ampicillin and amoxicillin, 20 to 30% to triprim, and 18 to 21% to augmentin fort. Patterns of resistance are dependent on the clinical setting. Residential aged care facility, which is often associated with higher resistance rates, and need to be taken into consideration when treating patients. In a pilot study in 2015 in aged care facilities, 11% of patients were receiving antimicrobials, but only 4.5% had a suspected or confirmed infection. Good antibiotic stewardship in the primary care setting is invaluable in safeguarding against the emergence of multi-resistant organisms. Targeted antibiotic treatment guided by sensitivities optimizes treatment success while minimizing development of antibiotic resistance. Now we'll talk about recurrent UTIs, which are 3 or more episodes of UTIs in 12 months or 2 or more UTIs within 6 months. As you can see from the slide, 50 to 70% of women have a UTI sometime in their life, and 20 to 30% of women have recurrent UTIs. 4% of residents in institutions develop recurrent UTIs. A study of non-pregnant young women in the USA showed around a quarter experienced at least one UTI recurrence within 6 months of their initial infection. We need to check that there's no anatomic or functional abnormalities of the urogenital tract in those with recurrent UTIs. We especially have to consider the likelihood of severe outcomes due to recurrent UTIs in those who are pregnant, have spinal cord injuries or neurological conditions, diabetes, and in the elderly. There's an increased incidence of UTIs in people with diabetes, and diabetes predisposes patients to more severe infections with significant sequelae such as pyelonephritis, papillary necrosis, renal abscess, sepsis, and increased risk of death. About 5% of pregnant women have bacteria in their urine. In contrast to their non-pregnant counterparts, spontaneous resolution of bacteria in pregnancy is unlikely. Pregnant women with bacteria in their urine should be investigated, followed by treatment with low-dose antibiotic prophylaxis during pregnancy if no underlying causative factors such as urinary tract obstruction are found. If left untreated, up to 40% of pregnant women with asymptomatic bacteriuria may develop pyelonephritis. In other words, lower tract bacteria in the urine, symptomatic or otherwise, is associated with a 20 to 30% increased risk of developing pyelonephritis. Now we'll look at assessment. In premenopausal women, it's important to consider whether or not the patient is pregnant, as there has specific treatment implications. In all patients, establish whether lower urinary tract symptoms were present prior to suspected infection, as this may indicate underlying voiding or functional abnormalities. Get a history of urinary tract surgery or trauma, pelvic malignancy, urinary incontinence, reflux, stones, flank pain, and pneumaturia. An abdominal examination is very important, and it may reveal a palpable bladder or the presence of flank pain. We need to be aware if there's vaginal or urethral discharge, and if so, it should be swabbed for culture, and we need to determine if it is vaginitis or STIs. In men, a DRE may be required to evaluate the prostate. In women, significant pelvic organ prolapse may lead to obstruction, resulting in persistently large post-void residuals and subsequent recurrent UTIs. It's important we note any prolapse on examination and document it. So dipsticks are the go-to for when someone has a UTI. Not only, as we know, will they let us know if there's nitrates or bacteria in the urine, they'll also let us know if there's glucose, and you know, they're not always perfect, but it does help to give us a rough idea. Obviously the specimen has to be a midstream urine specimen to ensure that we're not picking up bacteria from the genital area. Dipsticks are good, but sometimes they will miss infections, so we need to ensure that we're using our common sense about other signs and symptoms of UTIs. Now, if we note nitrites and leukocytes in the urine, we need to get a clean catch midstream urine specimen. In a perfect situation, a peri-toilet will be done before the specimen is collected, but if that's not possible, then definitely a midstream urine. And the urine must be processed within 2 hours of collection or refrigerated immediately and then cultured within 24 hours. If persistent sterile pyuria is found, it could be that the person has urinary tract tuberculosis, and then we'd need to get a first morning voided urine sample to be sent for acid-fast bacilli cultures. Other reasons for sterile pyuria might be stones, cancers, and the presence of urinary catheters or stents. A clean catch midstream urine is the most useful diagnostic tool. Other investigations we might do are listed in box 2. Imaging is not used indiscriminately. If we're worried that there could be urinary tract abnormalities, imaging and cystoscopy may be used. It can be really good for recurrent urinary tract infections if the person's immunocompromised, in women who are pregnant, and where the pattern of recurrent infections suggests bacterial persistence within the urinary tract. And then it may be that the person needs to go on to have referral to a specialist. This box will show you when imaging and possibly referral is necessary. So it's things like calculi, flank pain, hematuria, pneumaturia, and persistent urinary tract infection. Ultrasound for all of us as nurses is invaluable for us. Basically, we're looking at post-void residuals as a reason for chronic UTIs, but for the radiographer, they can look at reasons for suspected urolithiasis. It can provide important information about the lower urinary tract, such as post-void residuals and prostate size, but CT is more sensitive in diagnosing conditions such as renal, perirenal abscesses and urolithiasis. If there's persistent growth of urease producing bacteria, in particular Proteus mirabilis, we need to exclude stone formation in the urinary tract with CT. To effectively manage patients with recurrent UTIs, we need to address the underlying modifiable risk factors. So for premenopausal women, it's the use of spermicide and diaphragm use. We need to discourage that if women have chronic UTIs. In the postmenopausal women, the use of estrogen cream could be quite helpful to reduce their chronic UTIs. Urinary and fecal incontinence need to be addressed because this can obviously lead to bacteria getting into the bladder. People with spinal cord injuries can be difficult to diagnose because they can't localise the site of their discomfort. Visible blood in the urine is a clinical red flag for urological malignancy. Although you can get blood in the urine when someone has a UTI, it's necessary to investigate the presence of visible blood in the urine and the presence of infection and potential urology referral, as 10% of cancer presents with concurrent urinary tract infection. Urinary tract obstruction is another area that's associated with chronic UTIs or recurrent UTIs. Obstruction inhibits the flow of urine and increases the chance for bacteria to grow and adhere to the urinary tract. Lower urinary tract obstruction is revealed when persistently elevated post-void residuals are found, and hydronephrosis on imaging is suggestive of upper urinary tract obstruction. Mild cystitis or pyelonephritis can be life-threatening when obstruction is present. Therefore, an infected obstructed patient needs to be referred to the ED for urgent assessment and management. Now we're going to look at the use of antimicrobials for recurrent UTIs. Some people will need low-dose antimicrobial therapy. Sometimes it's daily or every other day or just post-coital. Initial duration of 6 months. 50% of patients experience recurrence by 3 months after discontinuation of the antibiotics. There was a study done in 1997 that showed no difference between post-coital versus daily prophylactic antibiotics for recurrent UTIs. Another study in 2011 showed 12 months of antibiotic prophylactic therapy had little difference between nightly antibiotics versus single-dose antibiotics with symptoms, and there were less GIT adverse effects with intermittent antibiotics. Now we'll look at non-antimicrobial ways of treating recurrent UTIs. There's the conservative measures of increasing fluid intake, voiding post-coitally, wiping from front to back, post-defecation. But there's really no strong studies to show that these behaviours reduce the risk of UTIs. Although we all know that they have some benefits, especially personal toileting and hygiene are very important. Lactobacilli is one of the newer ideas for the treatment of recurrent UTIs. Specific strains have the ability to adhere and to interfere with the growth and colonisation of the urogenital epithelium by uropathic bacteria. Certain strains produce antibacterial compounds like peroxide and biosurfactants, and they have the ability to enhance the microbial populations in the GIT. They can be given as a vaginal suppository, a drink or a capsule. Probiotics are another area that's quite commonly spoken about nowadays. However, a Cochrane review failed to show any convincing benefit from lactobacillus products in reducing the risk of UTIs, but it could be due to the difference between the amount of the lactobacilli in different preparation. Estrogen is another area that is a non-antibiotic method of dealing with UTIs. They restore the atrophic urethral mucosa, increase colonisation with lactobacilli, and lower vaginal pH. Current evidence supports the use of topical vaginal estrogen, but not oral estrogen, in postmenopausal women to prevent recurrent UTIs. Therefore, they should be offered to postmenopausal women with recurrent UTIs in the absence of contraindications. In my practice, I've found that even women who've had breast cancer, as long as they get clearance from their oncologist, they can be suitable for vaginal estrogen. Side effects of vaginal estrogen can be irritation in 6 to 20% of women. Vitamin C, there's limited data to say that we should be recommending vitamin C, but there was a study in 2007 in pregnant women who took 100 milligrams of vitamin C daily for 3 months, and it showed a subjective reduced incidence of UTI by 30%. Cranberry juice can inhibit the adherence of F. fibrinae of E. coli to the uroepithelial cell. In 2008, a study showed a significant reduced incidence of UTIs at 12 months. However, in 2012, another Cochrane review with 14 additional studies failed to show a reduction of symptomatic UTIs. And the side effects of cranberry are reflux and mild nausea, and the cost. Hiprex acts by producing formaldehyde. The urine needs to be below 5.5 for bacteriostatic concentrations of free formaldehyde to be produced. It's usually taken with vitamin C, 1 to 4 grams a day. It will not prevent infection with urease producing protease and possibly Pseudomonas, as these bacteria increase urine pH through hydrolyzation of urea to ammonia. A Cochrane review in 2012 found that Hiprex may be effective for preventing UTIs in patients without renal tract abnormalities or catheters, particularly when used for short-term prophylaxis. Treatment for 1 week or less showed significant reduction in symptomatic UTIs in those without renal tract abnormalities, but in 2011 formaldehyde was declared carcinogenic by the National Toxicology Program, so there's a theoretical risk of bladder cancer from Hiprex. D-mannose is a simple sugar that assists in preventing the adhesion of E. coli and other bacteria to the bladder wall. The bacteria can then be eliminated from the body during urination. It has minimal adverse side effects. It's metabolized the way other sugars are and therefore safe for diabetics, but also pediatric and geriatric use. So D-mannose sticks to E. coli, and then the E. coli is flushed out of the bladder. Symptom relief can be seen as quickly as the following day, and most symptoms are generally resolved after 48 hours of treatment. It can be taken prophylactically when there's an increased risk of UTIs, such as prior to intercourse and prolonged antibiotic treatment. Then there are the immunoactive prophylaxis. Urovaxone is an oral immunostimulant. Freeze-dried bacterial lysates derived from 18 different serotypes of heat killed uropathic E. coli. So basically it's like a vaccine. So the bacteria has been killed. Once daily oral capsule is taken for 3 months, and it activates both innate and adaptive immune systems, therefore enhancing the patient's natural defence mechanisms. There's Urovax as well, which is 6 different serotypes of uropathic E. coli, Proteus vulgaris, Klebsiella pneumoniae, Morganella morgani, and Enterococcus faecalis. It includes immunoglobulin G and immunoglobulin A in the urogenital tract, thereby reducing potential colonisation of the vaginal and bladder with uropathogens. Immunoimmune is a sublingual spray. There's a prophylactic benefit of sublingual spray, and it may be better way of giving the immunostimulant than via the oral or vaginal route. There were some minor adverse reactions in a study of 75 people, such as a postnasal drip, stinging around the mouth, pruritus over an old BCG scar, pruritus over the abdomen, and mild nausea. Treatment that's been used more recently is intravesical ILU-RIL. So in a healthy bladder, there's a natural barrier that protects the bladder lining from the urine. It's called the gag layer. If the gag layer is damaged, it may lead to direct exposure of epithelial cells to urine contents, which increases the risk of bacterial adhesion and infection. ILU-RIL contains two of the natural gags that form this barrier. By administering it directly into the bladder, these gags help to repair the damage to the gag layer and restore the bladder's protective coating, relieving chronic inflammation and infection. In people with spinal cord injury and high pressure bladders, recurrent UTIs can carry significant morbidity. These patients require care within a multidisciplinary framework, including GPs, neurologists, rehab physicians, and urologists. Many spinally injured patients require catheterization after their injuries due to spinal cord shock, resulting in bladder flaccidity. A significant number develop ureterocasis, which is narrowing of the ureter, hydronephrosis, reflux, and renal calculi. Advances in the management of urinary disease have vastly reduced their morbidity and mortality and should be an integral part of their care. In conclusion, recurrent UTI is a common condition. We need to distinguish recurrent reinfections from unresolved persistent infections, as the latter mandates further evaluation and a search for underlying causes. Circumstances such as obstruction increase the adverse sequelae of infections and may lead to sepsis and death. It's important to risk stratify patients, being aware of factors such as diabetes, which will predispose patients to more severe infections, such as emphysematous pyelonephritis, and the development of renal abscesses. Although investigations beyond FBC, UEC, fasting BSLs, and urine microscopy culture sensitivities are not indicated for those with uncomplicated bacterial cystitis, complicated UTIs warrant further assessment, supplemented by imaging and/or onward referral. After addressing risk and causal factors, one should consider the evidence-based use of vaginal estrogen in postmenopausal women with recurrent UTIs and use antibiotics judiciously in order to stem the tide of emerging bacterial resistance. Strategies to manage uncomplicated recurrent UTIs include self-start antibiotics, post-coital single-dose prophylaxis, and low-dose suppressive antibiotic prophylaxis. Thank you. I hope you've enjoyed this presentation and have gained some knowledge from it.